Okay, hello. My name is Graham Daniels. I am a psychoanalyst and author from Northern California. This is a video about, well, entitled Everything That Is Wrong, in My Opinion, with this variably called infidelity treatment or sex addiction treatment, problem or out of control sexual behavior treatment. The problem is given a variety of names in recent years. Perhaps sex addiction treatment has become the most commonplace name for it. And prior to that, it might have been infidelity treatment, I guess. To say more about myself, I am the author of a book entitled, or lead author of a book entitled, Getting Real About Sex Addiction. I am the recipient of a prize by the American Psychoanalytic Association for a paper entitled Treatment of Recovering Alcoholic with Substitute Addictions. I am the host of a podcast, first entitled Getting Real About Sex Addiction after the name of the book, that was published by Rowman and Littlefield in 2022, and now called Getting Real About Psychoanalysis, as I continue to write about psychoanalytic practice in addition to things like addiction. I have made presentations over multiple years to institutions like the San Francisco Center for Psychoanalysis here in the San Francisco Bay Area, the Society for the Advancement of Sexual Health. I've given a pair of presentations there over the years, even some presentations relating to applied psychoanalysis and the arts at a conference called Creativity and Madness, which takes place annually in Santa Fe, New Mexico. This video is intended as a critique, rather like the book Getting Real About Sex Addiction, of a niche industry that aims at sex addiction, again, infidelity, various other titles. More recently, I've heard titles like, deceptive sexuality. My further background is that I have been a mental health professional for roughly 30 years, starting out as a drug and alcohol counselor in the 90s. I became a marriage and family therapist. I worked, or initially in my career, for about a decade in hospital-based programs, mostly short-term um, programs based upon sort of cognitive behavioral theory and 12-step messaging, that sort of thing. I'll say more about those things as we go along. I've been a full-time private practice psychotherapist for just over 20 years. And I've worked a lot also originally, still occasionally, with patients, clients, patients who are mandated into treatment either as a result of a legal authority. This was particularly true with respect to substance abuse disorders earlier in my career, and also by familial mandates, ultimatums like get treatment or else. And this has pertained to substance use disorders, but also, again, well, broadly called problem sexual behavior more than any other label. What's my purpose here? What dog do I have in this fight? I've made occasional videos on YouTube and I've spoken out in my podcast about certain methods that I think are useful in the treatment of these issues, but I have no particular program to pitch here. I've got a book to plug, I guess, which I'll show a little bit later or speak to. But I have no particular program with a catchy acronym, attached to it. I suppose this video and my writings and my podcast advances the cause of psychoanalytic practice as it pertains to the treatment of addiction, and certainly the paper that I wrote relates to that. But my main purpose here is that occasionally I take it upon myself to, express a concern about the influence of, I don't want to call them factions, elements within the field of psychotherapy as a whole, that I think are, taking addiction treatment in a regressive, remedial direction, um, and whose principles are, for good reason, lack a platform in professional literature. They sell their models via the internet primarily, and they're quite popular, perhaps in popular psychology circles. Um, they lack a kind of scholarly, pedigree, and I'll say more about that as this video goes along. The conflict between factions or points of view, as an underlying theme, pits issues of privacy for patients, particularly those presenting as what I'll soon call the identified, patient, the person presenting with the problem behavior, versus the needs of non-identified patients, which can include not just family members, but the community, the state. In my podcast, I've also been a critic with respect to state legislation aimed at mandated reporting requirements for psychotherapists and other professionals. And to further give a bit of context before we go into something of a slide presentation and say more about this, there is a lot of evolving, changing ideas, conceptions regarding how to think of the problem, how to even name the problem. I think at this point, as being the late summer, early fall of 2025, and I've been writing and or thinking about this subject for many years now. I think most consumers of psychotherapy, or at least these niche fields within psychotherapy, are aware that the sex addiction term assessment label, it's really the appropriate way to describe it, is not a diagnostic label per se. It's a failed, if you like, diagnostic label. The closest it came to being accepted by either the AMA or the APA, the American Medical and Psychiatric Associations, was a 2012 into 2013 proposed diagnostic category called hypersexual disorder that was ultimately rejected. In 2017, the World Health Organization adopted what it calls the compulsive sexual behavior disorder, which outlines most of the behaviors and criteria that was going to go into the hypersexual disorder category, and more or less what people mean when they use the term sex addiction. However, the category that has been accepted by the WHO features an interesting exclusionary criteria element, that you don't an individual doesn't merit a diagnosis of the condition if the criteria for the diagnosis, the presenting diagnosis criteria, are entirely given on moral grounds. This was to thwart the possibility, perhaps even the prevalence, of individuals receiving a CSBD diagnosis, or previously a sex addiction diagnosis, or something like that, because their sexual behavior was not in line with values like religious mores, or possibly even more humanistic mores like use of pornography, or affair-seeking behavior was in violation of a kind of a progressive or feminist affectation about not objectifying women, for example. The clause states that you can't simply give a diagnosis based entirely on moralistic grounds, and the reason that's significant, that leads to my principal complaint about some programs in this field, is that they rely almost entirely upon moral arguments. There are and they generally short-term focus, short-term programs. They might even be not even deemed psychotherapy programs. They might be psychoeducational retreats, workshops, given those kind of names. They're led by people who are no doubt legitimate professionals in some way. They're licensed professionals as I am, and trained in mostly short-term psychoeducational models, which is what most people are trained in when they go to grad school and thereafter obtain a mental health license. But to do in-depth training requires years of postgraduate and specialized training. That's certainly true in order to become either a psychoanalytic psychotherapist, which I initially became upon completing a 3-year program that centered around personality disorder, and thereafter a further 4-year full analytic training, which led to my being accepted as a psychoanalyst. So in-depth psychotherapy is a much different animal than what is presented in short-term psychoeducational programs, and I'll give 1 or 2 examples of that a little later in the presentation. Short-term workshops slash educational lectures give a smidgen of science, particularly relating to addiction. You participant in one of such programs, you'll learn things which you probably already know about somewhat. You learn that addictive behaviors are dopaminergic. People will use that, professionals will use that kind of term to indicate that dopamine, the neurotransmitter most associated with compulsive behavior, is activated by pleasurable stimuli. So it's very scientific sounding language, and basically your brain gets habituated to pleasurable activity such as this, and thereafter the science goes that your limbic system rather takes over the mesolimbic system of the midbrain, and your higher functions, your executive functions, as they're sometimes called, your capacities for making good judgments, as it's plainly called, is quote unquote hijacked. People have heard this, the idea that your good sense gets overridden by the pleasure-seeking drive, if you like, if I can invoke a psychoanalytic term for the moment. This gets coupled with a fair amount of quite loaded sociological arguments and tropes that are perhaps in recent times of facing something of a backlash. I observe that the culture is wearying of being lectured about patriarchy and masculine entitlement, about things like the objectification of women. This, I think, is spawned by a generation or 2, possibly 3, of practitioners, particularly women who, or what is aimed at the feminine consumer base of psychotherapy, who've been raised to believe that it's more or less the charter of psychotherapy to critique masculine ego. And it begs the question, when these treatment models are so obviously sort of aimed at men, when you ask the providers what about the lack of women in treatment for infidelity, or again these plethora of other terms, the responses to that become sort of apologistic and sort of vague. I've seen numerous female patients over the years, either in my practice, dominantly my practice, I should say, who presented as, with affair-seeking behavior, even things like porn addiction and other such behaviors under the heading of out of control or problem sexual behavior. But rarely are they subject to the kind of pedantic treatment that male counterparts are recipients of, and that merits some scrutiny, actually. That gets precious little of it. There's not a lot of motivation to do that. Now, as I said, I'm going to dovetail this presentation with some visual aids here. I'm going to start bringing them up, partly to help me. Running off some notes here. I'm going to share a document. but also serve as a kind of guide for the viewer. A little bit of screen sharing going on. So, some concepts here that are important to this topic, this subject. Confidentiality will be, the first one I'll touch on. The basics. It's a norm of psychotherapy for individuals, patients, to receive confidential services. The individual receiving services is what we sometimes call the unit of treatment. So how psychotherapists, are trained to think about these things. And they are granted confidentiality or privacy, and there are legal exceptions to that, or commonly understood by the consumer, any indication of child abuse, um, any threat to self or other. Somebody is suicidal, for example. There are limits on confidentiality in these circumstances. The basic rule is that if you are a recipient of services, you have a basic right to privacy and, in legal terms, confidentiality. And this is not just a right. As optimal privacy is also that which is deemed conducive to effective treatment. Better outcomes, better symptom reduction, better, reports of psychological growth, both subjective and possibly objective criteria, suggest that privacy is not just a right. It is what we have thought for over 100 years to be the most effective form of psychotherapeutic treatment. But the question exists, and has existed obviously for a long time, for whom is privacy effective, and for whom is treatment meant to be effective, is the meta question beyond that. Now, I referred in the intro to mandated treatment programs, mandated treatment paradigms, wherein treatment is variably coerced by courts, the state, on behalf of communities. This is true very much earlier in my career when I was working in hospital-based programs and with substance use disorders. People had to pass urinalysis exams. In the field of infidelity or so-called sex addiction, the analogy was the polygraph, the lie detector, and to supplement these court reports, which would indicate whether a person had diminished, were continuing, or indeed had sort of halted the behavior that led to them entering treatment. And these limitations were put in place because they're meant to serve, the state or the community. So what I'm going to introduce here is the term infidelity et al., IEA, as I might refer to them hereafter. Treatment models borrow elements of the mandated model, because the patient in a lot of models that are aimed at this behavior is actually the impacted other, in the sense that it is the impacted other whose symptoms, if you like, are meant to be reduced as a result of the treatment. So, and if that seems a little counterintuitive or strange, it'll make more sense as I go along here. Going to the next slide, what I'm calling the moralistic basis for this paradigm, which is what I'm going to characterize as anti-separatist, has to do with the impacted partner, or what we'll call the IP1 versus the identified patient. I get that they have the same letters, has a quote right to know. So when a model presents this way, they're saying that the family member, the non-identified patient, the impacted other, has a right to know what's happening in the treatment of the identified patient, whether they're relapsing or not, whether they're progressing in some of the psychological way, whether they're improving their capacity for empathy, for example. As a result of their um, being informed, their symptoms of what is often diagnosed speculatively in some cases, others, um, people are actually diagnosed as PTSD symptoms are soothed or alleviated. Anxiety is soothed by knowing is the basic premise. The identified patient, or IP2, or sometimes dubbed the perpetrator or abuser, the person engaging in the problem behavior, is said to obtain relief from disclosure, and these what are often called accountability measures. Um, the accountability measures that might include disclosures of slip or relapse behavior being conveyed to an impacted partner, the same way you'd convey slip or relapse of a court-mandated person to the court, to parole, probation officer, something like that. Or a provider giving psychotherapy services to an identified patient might report either directly or indirectly through another therapist that the identified patient is, progressing or not in their, capacity for, empathetic understanding, of the impact on the significant other, etc. What's the problem with this? I have found consistently, whether it was mandated treatment of substance users or treatment of either individuals or in context of couples therapy, that there can be a performative, element to this, and especially so if the treatment model is short term, like a 28-day program, what is often dubbed a rehab, you know, week-long workshop or weekend retreat, whatever. you know you will, if you're a recipient of services, you are subject to this treatment, and your disclosures are you know relayed to your significant others by an informant intermediary therapist. You can participate in that and make disclosures, you know affect guilt, or exhibit guilt if it's authentic. But the reason for doing that is because there's something you get out of that. It's preservation of the relationship that has become threatened. You feel compelled to do that, and so it becomes kind of performative, in my opinion. It's common, relating to the perpetrator abuser. It's common in these kind of programs for treatment to be divided into these binary categories: perpetrator, victim. The grievances that are given a hearing in couples therapy tend to be unilateral. That is, really only allow for the complaints of the impacted other directed at the perpetrating figure. Complaints that go the other direction are often deemed to be excuses or deflections and so on. The interventions are designed to compromise confidentiality, or at least allow the partner, the impacted partner, a kind of consultant role in the treatment of the identified patient. So couples therapy in this context isn't really couples therapy as it's conventionally understood. It's more like individual therapy plus an expert witness. I compare this a lot with sort of the most egregious forms of adolescent treatment, wherein parents exert a right to know what's going on with their teenager, from everything to do with um, their drug use, perhaps some of the kind of delinquent behavior, or just their sex lives. And the parents who are most hardcore, about this, had this experience for somewhere between 20 and 30 years. If you tell this kind of parent that you're not going to inform them if their, teenage son or daughter is or is not sexually active, then you don't have a patient anymore. You person moves on. They basically want a therapist to act as an informant, and if you're not going to play that role, they won't hire you basically. And I have been happy to relinquish, those kinds of cases over the years because it's not in keeping with the spirit of psychotherapy, basically. Um, some would argue that, there's a difference, you could say, between it's inappropriate to compare adolescent treatment with the treatment, let's say, of adult men. I'll get to why I really mean adult men more, let's say more than I have already about that bias. But because adolescents don't have the political and economic power that adults have, of course. They have less money. They can't even pay for their own therapy in most cases, of course. I would suggest, however, that that kind of counter argument is largely irrelevant to the point here, because if an impacted partner is in a right to know sort of mode, and they're encouraged to be in that mode by practitioners, psychotherapists, and the IP2 is in the identified patient is in what is commonly dubbed, happy wife, happy life mode, then it sort of doesn't matter whether they have economic power or not. They still feel compelled to comply. Um, so, yeah, but doing harm is the pretext that is given for the limiting of confidentiality across contexts. This is always the case. In legal cases pertaining to mandated reporting requirements, that pits the constitutional right to privacy versus the need to keep children safe, for example, the need to keep citizens safe. Safety is invariably the reason given for the compromising of confidentiality. In the case of infidelity and et al., treatment, um, the pretext for reduced confidentiality is the harm suffered by the impacted other. It's more or less the same rationale as that of mandated treatment programs. But, there are important questions here. Do about what is impactful in the treatment process. Do problem behaviors abate, lessen, because subjects learn that behaviors perpetrate harm? Um, or, as a sort of nuance of that question, do problem behaviors lessen because subject, and here I mean the identified patient, learn that behaviors perpetrate more harm than previously realized? Okay, so the basic idea is people who seek affairs or engage in secretive or sometimes dubbed deceptive sexuality. Part of the rationale for being secretive about it uh, is the belief that were the behaviors made known, they would perpetrate some harm. They'd be in trouble, and the loved one would be hurt by that. So there's a kind of no kidding aspect to that intervention. Your behaviors are doing harm to your significant other. The real twist here is to add that did you realize how much harm was done, not just by the fact that you engage in the problem sexual behavior, but on top of that, most crucially, that you were keeping it secret, that you were lying about it when the impacted other was starting to get wind of an issue and then challenge you about it, and that you continue to lie about it. Now you're doing something that is especially traumatizing, becomes the basic psychoeducational lesson, and it is. it relies on a concept called cognitive dissonance, which is something of a mainstreamed psychological idea about the tension between contradictory beliefs. Now, cognitive dissonance, I should highlight here, is a when you have cognitive uh, dissonance, it's an instance of psychological growth. It means conscious awareness of a conflict within one's thinking. Problem of certainly compulsive and addictive behaviors, in many people's opinions, including mine, is the the problem of people going unconscious, going habitual, which is sort of synonymous. And in another context, I'll further the argument for why this is why a psychoanalytic method is important. But back to the idea of cognitive dissonance. This is a legitimate idea, so a legitimate element of the intervention. It's the idea that secrecy, which the person might think initially, well, secrecy protects from harm. That's one idea, but now that's in tension with a contradictory belief that is introduced, that it hurts even more for individuals to not have the truth. Um, and that's why it's deemed therapeutic to have not just things like polygraphs, which is a kind of externalized verification of disclosures, their truthfulness or not, but things like full disclosure exercises, which are formalized, people writing out the history of the sexual behaviors that impacted another, and reading it out, that kind of thing. One other point to make about this is that discovery, which is sort of a conceptual term in infidelity et al., treatment, uh, yields trauma, right? It's the knowledge of you learn that your partner has been cheating on you, let's say, and this yields trauma, but it's a sort of layered trauma because it's also about how a previous felt yet denied experiences are now revised. You felt, let's say, for some time that your partner was cheating on you, and then and the person was denying it all along, and it's sort of fashioned. You start to question your ability to determine what's true and what's not, and then you learn that your suspicions were true all along. That now is a trauma because you now have to revise, what was previously held to be true, that your felt experiences contradicted. And this is based actually, that I find that a lot of uh, modern practitioners who were not steeped in psychoanalytic theory are not aware that this trauma is actually based upon a 100-year plus concept in French called the après coup. It was originally called deferred action. It's a term coined by Sigmund Freud, the father of psychoanalysis, and you'd have to say also of modern psychotherapy. As early as 1895, in a paper called Project for Scientific Psychology, introduced the idea that an early experience, typically in childhood, that is misunderstood, receives a revision and an update in conscious life, typically post puberty. It's a very important idea and a progenitor of this idea of discovery yielding trauma. Okay, so moving on, one of the things, again, back to a critique, one wonders, others wonder, I wonder about the sustainability of guilt leveraging approaches. And sustainability of how much does it work to try to get somebody to feel guilty, for their behavior. And it certainly works in the short term and certainly works in the immediate aftermath of discovery. Person is, the person who perpetrating the behavior is frightened of the consequences that might befall them now that they've been caught, so to speak. and they're quite willing to be compliant because they're entering treatment because they're motivated to preserve the relationship that has been impacted, at least as much as to reduce the behaviors themselves. Some people enter treatment um, because they haven't yet been caught and they're motivated to stop the behavior before a calamity happens. But most people who are attending the kind of workshops that I'm critiquing here, they're doing so because they've been caught and they're willing to be compliant. But how sustainable is that, compliant, attitude is the question. And that doesn't get found out if the treatment itself is short term, a week, 2 weeks, a month, whatever. These models rely upon the what I'll call the ripeness versus the complexity of conscious guilt, and that leverages a compliance to didacticism and directiveness. A lot of you should in psychoanalysis is called a kind of superego kind of model of intervention. IEA models, really forsake, this is interesting, the meet them where they're at ethos, which is espoused by evidence-based motivational interviewing techniques and have really been quite influential, particularly in the treatment of substance use disorders since roughly the 1980s. But I think growing in sort of stature over the years, the idea that you don't just impart shame or anything like that. You use a non-directive, approach to, elicit the motivation of the patient, draw attention to, cognitive dissonance. You're examining the conflictual beliefs, feelings of the patient. It borrows from the ethos of psychoanalytic neutrality, really. And it's very popular. Some might even argue, a dominant ethos in the treatment of substance use disorders. Why not in the treatment of behaviors that many think are similarly addictive or resultant in compulsive patterns like affair seeking, porn use, and so on. I think a lot of that has to do with people's feelings about sex and our sensitivity to betrayals that pertain specifically, to sex. It is sort of, to be betrayed sexually is worse than most other kind of betrayals that people can think of. Economic betrayals, even political betrayals, what have you. And so to come back to the point, motivational interviewing is not so prominent in the treatment of infidelity, of sex addiction, or compulsive sexual behavior because the model's priority motivation is to prevent harm to an impacted partner. It's less a concern with the gradual facilitation of honesty or psychological growth for the identified patient. And the motivation of the identified patient is to avoid the adverse consequences of not being compliant and the lingering consequences of having engaged in the sexual behavior, as quickly as possible. The reason why they're more or less content to go into short-term, models, however expensive they may be in the short term. But it begs a further question, why would such models even require, a mental health professional versus pastoral counseling that was, religiously inflected and obviously sort of grounded in monogamistic, principles, or just a kind of pedantic just say no approach that recalls the approaches of the 1980s, the slogans associated with then First Lady Nancy Reagan and the long since regarded misguided idea that you don't stop people from doing behaviors or prevent by simply informing them that the behaviors are unhealthy or that they do harm to themselves or others or even the community. You know, it doesn't require a mental health professional to impart those messages. They can be imparted by lay counselors, by concerned members of the media. Um, so, a long-term model, or even something as derivative, that's like motivational interviewing, is takes a more patient, neutral approach. It doesn't treat the problem as an emergency per se. Now, short-term models obviously don't approve of this. They tend to be disparaging of approaches that are long-term or grounded in psychoanalytic, or what is sometimes called object relations theory, which proceeded from psychoanalysis. And we'll go into all that means at the moment. Or even addiction-related concepts like codependency. They think these models are sort of victim blaming and separatist. They deem the victim blaming because they would suggest, quite rightly, I think, that both um, identified patients and their partners, bring some degree of denial to the problem. It's a commonplace idea. But this is where we get into the area of why um, tried and true sort of ideas, traditionalist ideas, are sort of thrown out again when the anxiety is high and the matter is deemed urgent. One reason why the codependency label is rejected. I'll give an example of is deemed codependent behavior. It's the idea that spouses of identified patients, sex addicts, etc., they don't make excuses for them with bosses, for example. They think of the alcoholic who has slept in and missed work, and the codependent is the person that's called up the boss to say, oh, he's ill or she's ill. They're covering up for them. Or they get rid of their stashes, that kind of controlling behavior. The idea was that providers on behalf of impacted partners of cheaters, sexual miscreants, weren't doing those kinds of behaviors, covering up. They were kept in the dark. Again, the trauma was the discovery of the behavior, not that they knew all along and were compelled to just sort of put up with it by somebody staggering home drunkenly and saying, yes, I committed this, infidelity also, and just deal with it or something. No, that kind of notion of what a codependent is rejected. So a couple of points here. It's a bit facile. For one thing, impacted partners either before and after so-called discovery do engage in behaviors sometimes that are, I think, an average person would deem as controlling. Things like certainly tracking on cell phones as a contemporary phenomenon, that parents are doing this, partners are doing this. Who really has privacy could be a broader conversation, within this subject. They also do things like place, devices on vehicles and things to sort of track people. So there's a lot of, that idea to go around here. Um, what IE models really do is they overlook the concept within codependency that is about focusing upon others, versus a self. A dispute that individuals are having with their partners is often grounded in a confusion and ignorance as to what constitutes a defense, plus what is the essential, meaning of a defense. You know, Coming to this idea of what a defense is. A layperson view is that a defense or defensiveness refers primarily to denial of something happening or argumentativeness. But a defense isn't as simple as that. A defense is that which serves to avoid discomfort, protecting an individual. Individuals dissociate or they tune out or they don't notice or recall things. They undo uncomfortable thoughts with contradictions, confusion. A person says something that they then, regret saying, and they say, why did I say that? Affecting confusion. Can't she accept that I am the way I am is a thought that somebody might say within minutes of saying, I know I am 100% responsible for the behaviors that I do. They exhibit a contradiction when, within, a few moments, they're saying something that is somewhat blaming of the partner. Okay. Forgetfulness. Taking conscious positions that oppose secret desires, perhaps the term for this called reaction formation, which is a psychoanalytic concept, but its most famous example is that of homophobia. The idea of homophobia is the person is taking a strident position against feeling against homosexuality. But the reason for that is an underlying fear of their own same-sex orientation or desires. The goal basically of treatment is to challenge, not support defenses. Now, some defenses are conscious, like lying, superego defenses, like yes, I shouldn't do this, which is a defense insofar as it sort of skips over a genuine contemplation of ambivalence. I feel a desire, oh, I shouldn't think that, I shouldn't have said that. There's a sort of skipping from desire to, sort of judgment without really thinking about the process. It's thinking that psychotherapy is meant to elicit, not just a moving back and forth between you did this and you shouldn't do that. And these thoughts are often unconscious and habitual, which is why they require ongoing live attention. I draw attention to defenses as they're happening in the office. In some circles outside of psychoanalysis is commonly dubbed a here and now approach versus a then and there. The most effective treatment is that which observes how a mind is working in the therapeutic interaction. This is not about receiving isolated psychoeducational lectures. And unfortunately, a lot of programs seem to not indicate an understanding of this. Now, because defense is deemed a pathological or, quote, unhealthy behavior, the tendency is for impacted partners who are considered victims of another pathology is to, bristle when a defense is assigned to them. This is an example of what is deemed victim blaming. Somebody is said to be defensive. It represents a misunderstanding of the concept of defense. And it furthers a sort of moralistic, versus clinical and professional conception of defense. An example is the partner who would, complain, why is the focus on me? I'm not the cheater. Cheater is the focus of treatment. There's no other phenomenon that merits being looked at is the implication. Well, the other condition that merits being looked at is PTSD, which is a diagnosis, post-traumatic stress disorder symptoms, which are defensive in nature. The idea in psychology is that symptoms represent a defense, as in they are protective of the self, and they include patterns of dissociation, which, for the sake of argument here, means like tuning out. That's a crude sort of simplification, but of it. Hypervigilance, hyper and hypo-aroused states, alternating patterns of avoidance and preoccupation. This is confusing because people with PTSD, people who are traumatized, they avoid stresses as a defense, and they become preoccupied with stresses, which is often cast as a healthy thing. It's not so much healthy as it is in the service of survival. It's about as healthy as, say, it's like saying obsession is healthy. And it's because of the idea that knowing something, finding the answer, is healthy, but it's also another kind of compulsion. Defenses serve as protection and, by extension, survival. That's the problem. Long term, that they don't serve intimacy and psychological growth, which is why individuals, regardless of whether they are a wrongdoer in a moralistic sense, are encouraged to lessen their defenses. Okay, so let's look at a scenario, a commonplace scenario in infidelity et al. Treatment, as I'm calling it, a trigger, an interesting term borrowed by cross addiction and bad behavior paradigms. The identified patient has come home late from work or something. The impacted partner asks multiple questions because they want to know, and this exasperates subject. Person is evasive, and a fight escalates. The questions, they are, quote, understandable, say they're the advocates and treatment providers for the impacted partner. Understandable becomes equated with healthy, and it takes on a moralistic quality. You have a right to know, so it's an ethical argument. The subject, and here I mean the identified patient, is instructed by, say, in these programs that attend to individuals as a couple, to answer the questions and not argue, but it's not clear whether they're meant to affirm. And here we come to the point that no one would really know the premise of the following, unless we just perpetually used, and it should be added, trust polygraphs. There is a bind, a denial of the problem behavior, cheating behavior, let's say, is experienced by the impacted other as a lack of empathy or validation, which is said to be more or less the same. It's not, but anyway, pause that for now. And an affirmation, which we might think here is like a confession, also deepens the distrust. So the bind is a can't win sort of situation for the identified patient. A win meaning, what can I say, that could possibly, produce a positive outcome here. Reduce the tension, reduce the fight. And what we don't know here as a neutral is whether or not the person is indeed, telling the truth. We don't know that unless we perpetually use, polygraphs. So what if the subject neither confirms nor denies, but merely expresses understanding and concern for the partner's bind, the impacted partner's bind, which is the following: that if they discover an instance of cheating behavior, that yields emotional pain. If they remain unknowing because the person neither confirms nor denies, their anxiety continues. So they likewise are left in a state of feeling there's a no win here. And people basically don't like lack of resolution, which is why they perform and contrive things. So people affirm because they're choosing an answer, denying but choosing an answer. All right. Empathy in the mind of another. Long-term or in-depth treatment approaches develop the capacity for empathy via exploratory questions and interpretation. Basically, you ask, how do you think blank impacted them? And if they're not answering, you say, I think it's uncomfortable to think of the impact, so you shut it out. The interventions, which are repetitive, they seek to stimulate thinking and observe the defense against it. IEAs and other short-term models are more instructive as to what constitutes empathy, and they summon impacted others, a bit like court witnesses, to affirm or critique the psychological process of the identified patient. The interventions seek to supply rather than stimulate thinking. Regarding labels, addict, abuser, narcissist, the concept of addict rather unilateralizes blame. The notion of codependency notwithstanding, it's the fault and of the perpetrating behavior, and that's true, of course, in terms of the behavior that is the problem behavior. But what gets conflated in such messages is the idea that the perpetrator of behavior is therefore responsible for all or even most of the problems in the relationship. That all gets sidelined. Sex addiction, as I suggested earlier, has long been a controversial label. The ethos around accepting labels is that it allows for a quicker identification with the problem and taking personal responsibility or accountability, as it's sometimes termed. The same with the abuser perpetrator label. It's about accepting the assertion that problem sexual behavior plus the repeated deception is abusive. And I don't really have a problem with that. A real problem I have, I'll come to in a minute. And next, that the non-separatist collaborations, presume shared understanding of concepts like empathy and narcissism. So, for example, when I used to work on teams where, a therapist for an impacted partner would ask a question, say something like the partner just wants to know if he, meaning the identified patient, is, quote, working on his narcissism, which rather presumes a shared understanding of actually what is a complex, personality, disorder or phenomenon that exists on a continuum of narcissism. And secondly, the implication that the impacted partner is kind of an informed, witness and arbiter of such things, which is in itself a very questionable premise. The biggest problem with this model is the gender bias, which is rather obvious. IEA models, I think, trade upon essentialist biases about men and women, and implying that women generally do not, engage in deceptive sexuality. And as a result, these programs are dominantly aimed at men, employ a lot of sort of performative, man up and get honest kind of rhetoric, and alongside the heavy-handed labeling, while generally offering apologist, sympathetic explanations, sometimes vague explanations for women who engage in problem sexual behaviors. And this despite various studies suggesting that women's affair seeking has increased since the 1990s. Esther Perel, in her 2017 book, State of Affairs, cited studies suggesting that women's affair seeking had increased by as much as 40%. And that the primary reasons for, women's affair seeking was, quote, emotion-based reasons, an example of a vague term. Women's reactions to, quote, dull marriage. And doesn't that sound a little bit, blaming of partners, which is you're not supposed to do? And it's very much at odds with contemporaneous messages by, others in the field like Claudia Black. So this quote is from her 2009 book called Deceived. The kind of a tropish phrase, his behavior has nothing to do with you. So there's a kind of a double standard, and when it comes to, explanations of male infidelity versus female infidelity. And you tend to not get honest answers around this from providers of short-term programs that are aimed, dominantly at men. They don't mind giving their sociological theories as a subtext to, male sexual behavior, a lot of stuff about masculine ego, as I suggested earlier. When it comes to, women, you get, vague statements about, such women being, some of them being subject to sexual abuse, so they're really, victims who are sort of turning the tables, so to speak, possibly vengeance-seeking behavior against men. I think that alongside that, there are these tacit, sort of unspoken reasons why some of the measures that are aimed at male perpetrators are not aimed at women. A fear of masculine violence, I would suggest, tops the list. I hear of workshops where, couples attend and um, there will be multiple couples, and the partners, the impacted partners are all women, and the perpetrator, cheaters are all male. And I think if that was reversed and you had all female identified patients, I think it would be deemed, misogynistic, probably by an average, onlooker. And by onlooker here, I mean not just members of the public, but even, within the profession of psychotherapy. And there is there's an irony there, and I think an irony that is often not seen. It leads me to think that irony deficit disorder is, diagnostic category that I might contrive and propose and at some point. Really, just kidding. Um, so coming towards the end of this, say something about experts and just a little bit to finish up. How can you tell is a provider is an expert, leading figure in the field, or if their books are bestsellers, whether they are cutting edge or borrowing old school ideas and rebranding? These terms like cutting edge and old school, I think, are invoked to disparage, the pedigree of psychotherapy, which is indeed old, and merits learning, actually. But a lot of people are dismissive of ideas because they want to promote what they think are their new ideas. But check the credentials of the publishers of the works that you're reading. Are they peer reviewed? Are they scholarly? Are reference lists comprehensive? And references that represent research and theory over time, not just the last 20 years or something, indicating a breadth of research. Or is research or references displaced by so-called resource pages that's justified by kind of the virtue of being practical? I think it just reveals that people, some of these providers and authors, don't know the pedigree of their theories. Are publishers small press, print on demand, or are they, major distributors? And if they declare their methods evidence-based, which they commonly will, does this mean, can they substantiate, if they say this, via credible research, that their methodology is superior to other models? If they're on bestsellers, do they exist on USA Today, New York Times, Amazon, these bestseller lists, or are they more niche than they are letting on? Come out of the share just for the last few comments. Um, so I mentioned earlier at the outset that I have written a paper that was given an annual award by the American Psychoanalytic Association. Again, it's called Treatment of a Recovering Alcoholic with Substitute Addictions. I meant to indicate an individual who has had cross addictions to substance use, but also engaged in some of the other behaviors that I'm talking about here, primarily sexual behaviors. And I will be presenting this paper at a national conference of the APSA, or American Psychoanalytic Association, at the beginning of the new year. So that's about it for me. If you have things to say about this video and this material, feel free to do so. Click a like, click a dislike if you like, comment, and we'll see where this goes. Thank you for listening.